Hi, everybody. My name is Annalee Cawthorn. I'm with the Tennessee Commission on Aging and Disability. We serve as your state unit on aging, and we also provide administrative support for the State Palliative Care and Quality of Life Advisory Council. I'm very happy to introduce our speaker today, Dr. Justin Baker. He is the Chief of the Division of Quality of Life and Palliative Care at St. Jude Children's Research Hospital, the Medical Director of the Quality of Life for All team, and Director of the Hematology Oncology Fellowship Program. Since St. Jude first piloted its palliative care team in 2008, Dr. Baker has been deeply immersed in not only direct care with families, where his passion is rooted, but also systemic efforts to vastly increase the reach and impact of palliative care locally, nationally, and globally. Dr. Baker is a member of the State Palliative Care and Quality of Life Advisory Council, and we are grateful to him for providing this palliative care overview webinar today. Dr. Baker, I'll turn it over to you.
Thank you so much, Annalee. As Annalee mentioned, this is a palliative care overview. And I may be giving the presentation today, but this is actually a presentation by the State Palliative Care and Quality of Life Advisory Council. I'm very grateful to have the opportunity to serve on this council, and we're giving this on behalf of the council. So to start out, we really need to begin to understand more about palliative care. That's the entire purpose of our talk today. We want to think about what it is. We want to think when it might be appropriate. We want to think about who is providing palliative care. We want to discuss why palliative care. And as we think about that, we want to talk about the research and what research shows about integrating palliative care. I'm going to touch a little bit on the difference between palliative care and hospice, and then discuss with you some palliative care myths that are very important to dispel. Finally, we'll wrap up with a little bit on what matters most to our precious family members as they're approaching the end of their lives. So as we get started, it's incredible to think that approximately 90 million Americans, 90 million, are living with serious and life-threatening illnesses. In fact, the number of people living with at least one chronic illness has increased now in 2020 to at least 157 million people. That's incredible. 7 out of 10 Americans will die from chronic disease. Approximately 6 million people in the United States could benefit from integrated, high-quality palliative care. The illnesses that are most commonly treated by palliative care are things like heart disease, cancer, stroke, diabetes, renal disease, Parkinson's, and Alzheimer's disease. It's very interesting, though, because I'm right now an oncologist as well as a palliative care doctor. And so when we think about illnesses, as an oncologist, I treat the illness of cancer, or the disease that I emphasize as an oncologist is cancer. When I think about my job as a palliative care doctor, the disease I'm treating is actually suffering. Suffering is the enemy. And so even though we're talking about palliative care diseases that are being treated are things like heart disease, cancer, stroke, it is really in the context of those entities, it is working to address the suffering, and it helps to improve the quality of life of our patients, families, and caregivers. If palliative care were fully integrated into all the nation's hospitals, the total savings could amount to $6 billion per year. Palliative care is one of the very few things that clearly pays completely and fully for itself. So you might ask, I still don't understand what palliative care is. Dr. Baker, what is it you're talking about? Well, palliative care is specialized care for people facing serious illness. It focuses on providing relief of suffering, as I just discussed. That suffering may be physical, psychosocial, spiritual, and it aims to maximize quality of life for both the patient and the family. This is, on our council, this is the definition that we use. And when we think about the term serious illness, because then you should ask me that as well, Within palliative care, serious illness is defined as a health condition that carries a high risk of mortality and that negatively impacts a person's daily function, negatively impacts a person's quality of life, and or excessively strains the person's caregiver. So these are the definitions that we're incorporating today. You should also be wondering, when is palliative care appropriate? Well, to know when it's appropriate, you have to recognize that palliative care is provided by a team of trained healthcare professionals. And our teams at our hospital here at St. Jude, our team's actually called the koala team. That's why I have this koala here behind me, and you can see my little koala bear here. Koala stands for Quality of Life for All. And our team has on it doctors, nurses, psychologists. We work with social workers, chaplains. We have advanced practice providers who do a tremendous amount of our clinical work. And what we do is we offer services such as these listed here. We help provide relief from pain and other physical symptoms. We aim everything we do at improving quality of life. Again, our team is called the Quality of Life for All team. We provide support to the seriously ill patient, as well as to the family and friends who love and care for them. We help assist the patient, family, and staff with medical decision-making. And frequently we help with communication issues. So hey, when you think about when is palliative care appropriate, think of all of these interventions, and whenever they may be needed, we can think about integrating palliative care. So patients who are coping with a serious illness can benefit from palliative care at any time during their treatment. These patients may, in fact, still be receiving treatment aimed to cure their underlying disease. I think this is a helpful graphic here to think about care as it moves forward in a chronic fashion throughout the illness trajectory. And at the very beginning, as treatment is more disease-directed, we can think about palliative care competencies being integrated into people like oncologists, or into people such as cardiologists or internal medicine providers. And we need to think about those core competencies in palliative care being integrated throughout the healthcare system. And we may call this primary palliative care. But then we have to be thinking about specialty level palliative care. Once suffering gets a little bit beyond the scope of what somebody in that field may traditionally deliver and work with. And so we really then think about consulting a palliative care expert team. And this graphic, there's no specific time for that, but it is very important to recognize that when a patient is suffering, we should be thinking about integrating palliative care, and that palliative care can be delivered concurrently with disease-directed treatment. Interestingly, there are some differences between palliative care in pediatrics and palliative care in the adult world. In pediatrics, some of the most common diagnoses we deal with are things like genetic and congenital issues, neuromuscular issues, cancer, as we see here at St. Jude Children's Research Hospital, respiratory, GI, and cardiovascular. And you can see about 3/4 or almost 80% of our patient population could be made of patients with congenital or genetic disorders, as well as neuromuscular disorders. In the adult world, it's extremely common to be dealing with things like congestive heart failure, chronic obstructive pulmonary disorder, or COPD, cancer, or Alzheimer's disease, or other types of dementia. This may sound complicated. It might seem difficult to think about how it is that we could address issues related to suffering in so many different contexts. Well, it's critical to know that it's no one person's job. And one way that we're able to do this is to look at a holistic approach towards patient and family care. And in order to do that, we have to think about who is it that provides this care. Certainly, there are doctors and nurse practitioners, such as myself, who evaluate and treat symptoms, assist with complicated medical conversations and situations, help establish goals of care that are consistent with the beliefs, values, and wishes, and help kind of coordinate the overall care of that patient and their family. There may also be case managers who provide resources and placement options and work with members of the primary team to coordinate home needs. They may also help with nursing facility placements or hospice support when appropriate. And we're going to talk, as I mentioned, a little bit later about hospice. There are social workers who help incorporate or who are incorporated into palliative care teams. And those social workers provide emotional and social support, and they help understand healthcare planning for the future, such as creating an advanced care plan, making sure that patients' wishes are carried out. Pastoral care certainly plays a critical role, and chaplains and other pastoral members of pastoral ministries are there to help maintain the important role that faith and spirit play in the lives of patients. In the pediatric world, we work very regularly and routinely with child life specialists. These child life specialists meet with children and their families to help discuss and understand difficult situations that pediatric patient may face. They help us communicate with the child, perhaps through art therapy or sometimes even through music therapy. And clearly, we have to have an integrated pharmacy staff that helps ensure that prescriptions are accurate and assist in the acquisition of unusual or difficult to obtain medications necessary to treat symptoms. There are myriad other members of the team that may be present, but these are just some of the roles as we described them. The palliative care team's tasks may include some of the things that we've already described and discussed. One of the key issues to realize is that suffering, as we said, suffering, that disease of suffering or the suffering as an entity may come in many forms. So suffering may come in the form of physical suffering from symptom issues. And so we may need to have the task of symptom management. It may come in the context of uncertainty or difficulty with communication. And so we may have to work with communication facilitation or helping with shared medical decision-making. Suffering certainly comes very regularly from all the people that are involved in the medical community coming in and weighing in and everybody addressing each of their little issues, but nothing completely tied together. So that can cause suffering. Even though we're all trying to do our very best, we frequently work in silos. So it's quite common that the palliative care team work on issues related to care coordination. Sometimes suffering is caused because a family and the patient don't want to be in the hospital setting and need to be transitioned to home. And we can help with that. Sometimes as the disease is progressing and as the goals of care may change from a position where life prolongation or cure-directed treatments are most important, we may then help families come to a decision that we don't want to be in the hospital anymore, that patient and family want to emphasize, again, quality of life in the home setting or any other variety of issues. So we may have to discuss limitations of intervention orders, such as do not attempt resuscitation orders. Or here in the state of Tennessee, we use a physician order for scope of treatment, a post order. And that's one of the recommendations that we may make at end of life. And certainly the palliative care team is there to help support grief and bereavement issues. And one of the most important things we can do is address suffering while that patient is still alive to help with that grief and bereavement period. But then we must also include in our care plan an appropriate bereavement care plan for those surviving family members. So why is palliative care necessary? Well, I have to tell you, it is necessary because suffering is so abundant. You can think about suffering in any number of ways. We've talked about it through many of the slides, but illness leads to suffering. Our job as palliative care providers is to intervene, or at least begin to address issues and make sure that in the midst of really difficult times, that we are journeying with our patients and families, addressing, attending to suffering as it comes in any variety of ways. You might ask, it seems like you're talking an awful lot about different interventions that you provide, but I mean, does it really make a difference? That's a really important question. The research has really started to mature over these last many years, and it's quite clear that palliative care improves the quality of life for the patient as well as for their loved ones, as well as for their care providers. Palliative care clearly improves coordination of care. Early integration of palliative care increases patient and family satisfaction. In many studies, there have been better clinical outcomes for patients that are served, including those that are served earlier and earlier in the illness trajectory. There's improved symptom management and decreased suffering from symptoms that has been demonstrated. And in part, much of this research actually comes because of this improved holistic approach that is taken. When that approach is taken, it's also demonstrated that there's more likely to be discussions surrounding goals of care and advanced care planning. There's improved utilization of care, and actually the care is more goal concordant. Fascinatingly, and I think this is absolutely critical, when we talk about cost savings, when palliative care is integrated earlier and when there's a more robust palliative care team at a hospital, there is improved staff retention because there's decreased moral distress. There's increased efficiency as well. I think it's very interesting that when we discharge these very sick patients, you would think they'd have to come back to the ER more regularly. But because of that holistic approach that we take, there's actually a decrease in emergency room visits. Additionally, there's a decrease in length of stay and ICU days, and a decrease in readmission rates. So when you put all this together, it's quite amazing because these patients seem to live longer. They seem to live better, and they seem to be less expensive to care for. So it truly is kind of that perfect trifecta where patients are living longer, better, and are less expensive to care for. So why would we not be integrating this more and more? That's a question that's difficult to answer because the research is really starting to bear out that we need to have this widely expanded across the United States. And I'm so grateful for the state of Tennessee for creating this council so that we can continue to advocate in ways such as we're doing today for palliative care integration that is so critical. Palliative care, as I mentioned, improves cost effectiveness. You can see here that it reduces avoidable spending and utilization in all settings. It decreases costs in the inpatient setting by 48%, decreasing readmissions by 48%. In the outpatient setting, it decreases costs by decreasing admissions by 50% and ED visits by 35%. In skilled nursing areas, it decreases costs by decreasing hospital and ED transfers by 43%. And in home-based care, it's amazing that integration of palliative care decreased total cost by 36%. So across all of these settings, integration of palliative care decreases costs. And I already told you that it's great for the patient and great for the family and great for the staff. Sometimes palliative care and hospice are used interchangeably. That's actually not correct. Palliative care is for any patient with a chronic and or serious illness. Palliative care is really aimed at addressing suffering. Patients can receive palliative care at any age, during any stage of the illness. You can have palliative care services while receiving curative treatment. The payment mechanism for palliative care is actually mostly through Medicare Part B. Hospice is actually a type of palliative care. So it's a pillar of palliative care. It's a tool that we use in palliative care to provide care for terminally ill patients who are no longer receiving curative treatments for their disease. Interestingly, in pediatrics, you can receive hospice-related home-based care concurrently with cure-directed treatments, with life-prolonging interventions. You still have to be hospice eligible by having a high likelihood of dying in the next 6 months. However, we can provide those interventions concurrently. And as I mentioned, hospice patients in general, unfortunately, have only weeks to months to live. Patients become hospice eligible when there's a high expectation for them to die within the next 6 months. The payment mechanism we mostly utilize for hospice comes through Medicare Part A. So as we try to just tear down some of the myths, I just think we need to call these out. And you've heard me talk about these throughout this conversation that we've been having today. But first palliative care myth is that the patient must be at end of life. That's just not true. I've told you time and time again that palliative care is in place to address suffering. Another myth is that palliative care is the same as hospice, and that hospice and palliative care mean that we're giving up hope. I have this picture behind me, and it's so important. I worked with these bereaved parents to help create this picture in the background, and it's a picture of how they feel hope is woven in even to the moment that their child is dying. They remain hopeful even in the midst of these really difficult situations. So we're never giving up hope. We may be hoping for different things, but we're holding hope all the way through the end of a patient's life and beyond, as those relationships continue even into the bereavement period. Another myth is that patients must have a DNR to be in hospice. That's not true. Patients certainly do need to have that high likelihood of dying in the next 6 months, but they don't have to have a do not attempt resuscitation order to be in hospice. There's very frequently the thought that hospice or palliative care is really only for cancer patients. It was in the context of cancer that hospice was first utilized, and a high percentage of patients with progressive cancer utilize hospice, but hospice and palliative care are available for any patients that may be for hospice, in that case, in the last 6 months of life, and palliative care for patients with serious illness, as we've described. Palliative care, you most certainly do not need to abandon disease-directed therapies, as many people think. In fact, it's quite common that, as I showed on the slide, that palliative care and curative or disease-directed therapies are interwoven. A huge myth is that opioids, when provided in an appropriate way, will hasten death. What we know is that for patients in pain who have serious illness, that if we treat their pain appropriately, they actually live longer. Opioids actually do not hasten their death when used appropriately. And the same can be said for palliative care. When palliative care is integrated well, I'm of the belief that the reason that patients actually usually live longer is because we're emphasizing those things that matter most to them, filling their days full of life, and that then allows them to have a positive outlook. It allows for their caregivers to receive better care as well. So palliative care certainly doesn't mean the patient will die sooner. It may well mean the patient will actually live longer. It's very important to also know that for those administrators listening to this talk, palliative care drives a positive patient experience. It improves the quality of life and symptom burden. The quality of life is improved, the symptom burden decreases, and symptom distress decreases by as much as 66%. And you can see here that it drives a high satisfaction and positive patient experiences. In fact, 93% of people who received palliative care are likely to recommend it to others. That's incredible, 93%. Frequently, unfortunately, it is clinicians, it is doctors, it is other care providers who get in the way of early integration of palliative care for their patients. But once a patient is addressed by the palliative care team, it is 93% of the time that they are likely to recommend it to others. As we begin to wrap up, as patients are approaching the end of their life, it's quite common that we have to think about those things that are most important and what matters most. 60% of people say that making sure their family is not burdened by tough decisions is extremely important. Unfortunately, 56% have not communicated their end-of-life wishes. We have to recognize that every patient should have the opportunity to participate in decisions regarding the type of care, type of treatment and services they want before they are faced with end-of-life issues. Palliative care teams are expert at addressing these kinds of things. As we close, it's been fantastic that there's been the creation here in Tennessee of the State Palliative Care and Quality of Life Advisory Council. This was one of the 2017 Palliative Care Task Force's top recommendations, the creation of this council. And in April of 2018, the General Assembly unanimously passed the legislation that was signed into law on May 15th, 2018. There are currently 11 members on this advisory council. I feel so fortunate and grateful to be one of those members, and it really has been wonderful serving on this council. Council members are appointed for a term of 3 years, and it's advisory in nature. We're there to help guide the Tennessee legislature. And we have an annual report that is due to the General Assembly, and we provide that. We provide input into that report. The purpose of the council is to continually assess the current status of palliative care in the state of Tennessee and to review the barriers that exist that prevent such care from being obtained and utilized by people who could benefit from palliative care. So what we do is we look at the state as a whole, and we try to say, what are the barriers? What's in the way? One of the things that we recognize is there was a real barrier still within the state. What is palliative care? And that's why I'm with you today. Additionally, we provide recommendations to the governor and to the General Assembly on issues related to its work. It's been my privilege to be here sharing with you about this today. I'd like to really once again promote that palliative care is appropriate for patients with serious illness who are suffering. That we must take away the stigma of palliative care and recognize that it's there to promote positive quality of life, and it can make a tremendous difference. I encourage you to go to this website, www.tn.gov/aging, to learn more about this. Additionally, if you have other questions, you can email me at my email, which is provided here, or you can email the Tennessee Commission on Aging and Disability. You can either call them at this number or email them at the email that's on the screen. It's been a tremendous privilege speaking with you today. Thank you so much for the opportunity.
Thank you, Dr. Baker.
Did you think that was okay?